start recording this, which is also a logistical note to say this webinar is being recorded. And if you would like a link to the recording to watch again or to share with colleagues, I will drop my email in the chat at the end of the session, and you will be able to share it and access it on an ongoing basis. My name is Katie Hyman. I am Director of Palliative Care at Long Beach Medical Center in Long Beach, California. And I am really pleased to welcome Dr. Sarah Byrne-Martelli as our presenter today. Sarah is a chaplain and bereavement counselor who served in acute care and hospice since 2002. She's the inpatient chaplain and bereavement coordinator for the Massachusetts General Hospital Division of Palliative Care, and she serves on the faculty of the Harvard Medical School Center for Palliative Care. Sarah has a Doctor of Ministry from St. Vladimir's Orthodox Theological Seminary and a Master of Divinity from Harvard Divinity School. One more logistical note before I turn this over to Sarah. This is a Zoom webinar format, so if you're a participant and attending in real time, your camera and microphones are turned off, but I do highly encourage people to use the chat function to introduce yourselves and use the chat and Q&A functions to put your questions in. I'll gather those. We'll have a time for Q&A at the end, and Sarah can address all of your burning questions. So with that, I will turn it over to Sarah.
Thank you so much, Katie. I just want to say it's an honor and a pleasure to be with you all. And I look forward to having some great conversation. And this is an area that I'm super passionate about and interested in. And I think it's really a dialogue as we keep kind of growing and changing as a profession, as spiritual caregivers. And I work within palliative care, but of course, this really applies pretty broadly, I think, in many ways. I worked in acute care, also in home hospice for 10 years. And so I really welcome everyone's experiences and viewpoints. So with that, I'll go ahead and share my screen. Okay, here we go. Thumbs up. I think I'm going to assume it's fine. So we called this Beyond Presence, taking spiritual assessment to the next level. So I will talk a tiny bit about spiritual assessments, some options that we have as chaplains, but this is more about how we think about assessment and how we communicate it to the team, within our team with words and conversations, but also with our documentation, which is a really important area that I think is still being developed. So the objectives for today are to articulate elements of the PC7 spiritual assessment, to effectively translate spiritual assessment into the electronic health record for an interprofessional team, identify how effective documentation of spiritual assessment can be used as a tool for patient and family advocacy, right? Not just as a record, but also a way that really shows the care that we're doing and advocates for our patients and families' needs as we are a part of the team, and also apply the skills and knowledge presented in at least 2 cultural, ethnic, and religious contexts. So no talk about palliative care would be complete without a brief touch upon Domain 5. The NCP guidelines indicate that spiritual, religious, and existential aspects of care are a fundamental core aspect of quality palliative care. And we hold this as a value, but I know that the levels of staffing and of integration of chaplaincy, it varies. And so I think it's a good point to kind of just review kind of some of the basics about integrating and collaborating chaplaincy with the team in general. So I won't spend a ton of time on the next section, but I will visit this just so we can kind of get all on the same page, me using the same language. So we talk now about spiritual care generalists and specialists. So here's me with my team. This was April 2020, so this was a challenging time, but there I am in the front. There's my social worker, chaplain, 2 physicians, an MD and NP fellows. And so really this, for us, I was in a new role actually at MGH. I was the first dedicated palliative care chaplain on the team for palliative care at MGH. And it's a big, long time existing palliative care program. And so COVID really changed things for us. And we really started working as a team together. And I think we started to understand that it's really more patient-centered. It's actually holistic, collaborative, less isolating, much more professionally satisfying, and more efficient. So for us, it actually changed the way we do the work. And now we do this. This is how we work every morning. We meet together. Of course, we we love to define spirituality. It's important to do so. And I like to use the George Washington Institute of Spirituality and Health's definition. Spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. And it's important because when we're doing spiritual assessments and communicating this to the team, it's not just about the patient's background and what we did during the visit, but instead it's about themes and the bigger picture questions of meaning and purpose. I like to include this slide. It used to be just clergy were working as chaplains, right? Or, denominational support was happening. But now we have this profession that has really evolved to look at board certified chaplains by service line, whether we're palliative care or peds or cardiac. There I am on the bottom during the COVID pandemic officiating a wedding, which was a new thing for me. I just like to remind folks that we come from such diverse backgrounds, but we really are all there to provide patient-centered care. And also in the 20 years I've been a chaplain, I've really seen spiritual care referrals evolve briefly. Instead of things like the patient's dying, so they need a prayer, or the patient's very religious, so they need a chaplain. The patient's not religious, they don't need a chaplain. To the patient has spiritual distress around this issue. The family is talking about miracles and healing. The patient is ready to die, but the sister wants her to fight. So instead of thinking of it as religious versus non-religious, or spiritual versus not spiritual, the most religious person may be doing fine and have the spiritual support they need. The most non-religious person or non-spiritual person may also be doing fine. It's those in-between places where we're really seeking to address unmet spiritual needs. Not everyone needs to see a chaplain, just as not everyone needs to see a social worker. Not everyone needs, a psych consult or a pain consult, but instead we're trying to identify those patients on our own, but also to really work with our team so they know, because we really rely on referrals. Often there are not that many of us on the team. And so we really want to go where our skills are most needed. So again, briefly, spiritual history can be done by any clinician. Spiritual screen can be done by any clinician. And a spiritual assessment is what is done by a chaplain. So a spiritual history is really part of a good social history, right? Questions to gather information about the patient's and family's background, their community, their religious and spiritual preference, and how this might impact care. And so this is something that's sort of part of their demographic almost. One tool that people have often been taught and use, and I think is easy and works pretty well, faith, influence, community, address, FICA. Faith, I think now we're trying to broaden that because sometimes many religions wouldn't call it like their practice as faith, or it sounds more like a Christian term, but faith or spiritual belief. Influence, are these beliefs important to you? Do they influence your care? C, community, are you part of a spiritual or religious community? And A, address, how would you like your provider to address these issues with you? So again, this is something that you can do at the beginning of getting to know a patient, but it's not like a super dynamic thing, and it's not always the best source for referrals. Again, a spiritual screen, though, is really the way that we can identify which patients need a more in-depth spiritual assessment. So this is George Fichette's definition. But a good model of spiritual or religious screening employ a few simple questions, which can be asked by any healthcare professional in the course of an overall screening. So here's some questions that you can use to get to that place of assessment. And these are questions that I use too, of course. I mean, it can be a way for the dialogue to really open up when you're getting to know someone. Is your religious or spiritual practice important to you? If so, how can we support you while you are here? Where do you find strength? That's always a good one. What's keeping you going through all of this? Someone might say my family, some might say my faith, some might say my meditation practice, some might say music, but that's a way to assess what is supporting someone when they're in a spiritual crisis or a health crisis. What's the hardest part of this for you? What are you hoping for or worried about? All of these are great ways to quickly screen for spiritual distress so that you can refer to the spiritual care provider. I also like this one. This is kind of interesting. It's from the Edmonton Symptom Assessment Scale, but it also includes spiritual pain. So it's a lot of text, but if you look, it's like pain, fatigue, nausea, depression, anxiety. At the bottom, spiritual pain. Can you rate your spiritual pain, which for these purposes is defined as pain deep in your soul or being that's not physical. What I like about this is it reminds us that a spiritual screen is something that is done more than once, right? We don't ask just on the first visit, do you have nausea, and then never ask again. Similarly, we might say, are you having spiritual pain? And then they might say no, but then a week later, something might happen, a change in prognosis, a procedure that gives them spiritual pain. So again, it's important to kind of find a way to work this screening into your everyday screening about pain, fatigue, nausea, sleep, feeling well-being. How are you feeling inside yourself, or how are your spirits? That's always a good one too, I think, that people can relate to. And just as a reminder, patient and caregiver spiritual concerns are frequently overlooked by healthcare professionals. And the thing is, we know that religious and spiritual values often guide meaning making, coping, comfort, peace, quality of life, grief and loss. And this coping can be negative or positive and can profoundly affect decision making. There's a lot of good research coming out. I recommend looking at Transforming Chaplaincy. They have tons of webinars and handouts. They have one that's like 20 top 20 tips, research tips about spiritual care. And it has these wonderful citations and studies, but we're getting some good research finally about religious and spiritual coping. We know that spiritual distress is associated with poor health outcomes, and we can define spiritual distress as a person's impaired ability to experience and integrate meaning and purpose in life through connectedness with self, other art, music, etc. So when we are aware of spiritual distress, we can assess it and address it with interventions, but we won't know who's distressed unless these screenings are happening. And just a reminder again, there's some great research that's been done in the past 15 years associating spiritual distress with poorer health outcomes, including greater physical pain, functional limitations, and poor quality of life, increased mortality, increased risk of suicidal ideation, diminished quality of life, increased anxiety, and requests for euthanasia or physician aid in dying. So we want to have this on our radar as much as we can. And again, spiritual or religious coping can be positive or negative. So if someone has positive religious coping, and of course it's not always just one or the other, right? It moves on a continuum, but someone might find peace and comfort in their prayers, or they might find distressing existential experiences and feelings that are coming from their religious background or their spiritual background, giving them fears about the afterlife, about what's going on with them, about death or dying. And so our role, if we or our fellow colleagues hear these kinds of terms, I'm afraid I'm going to hell, or I'm worried that I won't see my mom if I die. I know she's in heaven, but I don't think I will be. Those kinds of things. Again, those can be a trigger to speak with your colleague who's a chaplain. So here are some handy triggers for spiritual assessment that you might hear when you're doing a screen or just in the course of regular conversation. Concerns about healing, hope, and miracles. Anytime anyone says anything about, I'm waiting for a miracle or I'm hoping for a miracle, ding, please call the chaplain, because we are good at talking with folks about these things, both in terms of theological and spiritual meaning making, but also really aligning with the team, with the medical team, as a member of the team to talk from our role as a member of the team, but also to utilize maybe the language, the kind of framework, the worldview of people who are thinking about hope and miracles. Religious or existential conflict within the family. We see that a lot. Struggles to find meaning, fear of death or dying, end of life spiritual ritual, of course, and negative religious coping, kind of this coping that is hurting someone or causing shame or guilt or fear or making them feel paralyzed. They can't make a decision about what to do next. And here we are at the what is a spiritual assessment, which is kind of what I really want to talk about more today. So a spiritual assessment is a more extensive, in-depth, and ongoing process of active listening to a patient's story is that it unfolds in a relationship with a professional chaplain and summarizing the needs and resources that emerge in that process. The summary includes a spiritual care plan with expected outcomes, which should be communicated to the rest of the treatment team. So these are some topics that a spiritual assessment focuses on: sources of spiritual strength and support, existential concerns, lack of meaning, existence, questions, who am I? What is the point of my life? Concerns about relationship to God or the holy, struggles related to loss of faith or community of faith or spiritual practices. This was a big one. I mean, I see it a lot. I think people become estranged from communities, either just from being in the hospital or being away from their normal community and their people. Or during COVID, obviously, we saw this incredible isolation from your family, from your social support, from your religious or spiritual community, and not even being able to access many of the liturgical or sacramental practices that normally would help you feel connected to that faith community, right? You know, the priest couldn't go in and provide sacrament of the sick, which for, you know, in Boston, we have a large Catholic population, and navigating that during COVID was incredibly difficult. And we along with all of you, I think, worked very hard to find ways to navigate that. Cultural norms and preferences, you know, hopes, values, and fears, meaning and purpose, quality of life. What does it mean to have quality of life? It's not the same for everyone, right? For some people, quality of life means being able to go for walks, or being able to garden, being able to be outside, being able to play with your grandchildren. For some people, it means, you know, we had a patient, I remember the team was sort of like, wow, this doesn't seem like quality of life. But for her, she didn't care. As long as she could sort of sit and be awake and watch her favorite shows on TV, she couldn't really do anything else, but she was perfectly happy doing that. So a reminder to be curious about what it means to have quality of life, right? And not to assume. Concerns or fear of death and dying, spiritual practices, relationships, life completion tasks. Now, this is a big list. Not everything applies to everyone, but what I like is I'm going to describe the PC7, which really gives us a good way to think about this. So the PC7 came out in the Journal of Palliative Medicine in 2019, and it's really the first quantitative evidence-based spiritual assessment. It's currently being assessed in 2 multi-site studies, a prevalence study, so looking at how much spiritual distress is there with patients approaching end of life. We might think that we have a sense that people have spiritual distress at end of life, but we actually have very little data on that. And then there's also a validation study. So I'm involved in the prevalence study, looking at the prevalence of unmet spiritual concerns at end of life. And it's a multi-site study. So we're drawing towards the end of that. So that's really exciting. And here is the PC7. The PC palliative care, and 7 is it identifies 7 themes that are related to spiritual distress with patients approaching end of life. So the 7 themes are need for meaning in the face of suffering. And there's indicators, and then you give it a score of 0 to 2. 0 plus is like, I didn't quite fully assess it, 1 or 2. There also could be a need for integrity, a legacy, generativity. What is my legacy? What am I leaving behind? Look at my family, kind of those kinds of things. Concerns about relationships with family or significant others. Concern or fear about dying or death. Issues related to making decisions about treatment, which is, I really think, an area where chaplaincy can really use our skills to work with patients to understand what gives them meaning, how they discern, how they make decisions, right? Is it through their faith? Is it through their meditation practice and listening to their inner voice, their inner experience? Is it through their family relationships? Sometimes we have the time and the bandwidth to really dig in and understand more deeply how people are making their decisions, and we really can bring that to the team. Also, religious or spiritual struggle, and then other dimensions, which would be kind of other really specific concerns that patients have related to spiritual needs at end of life. So just to illustrate this a little bit, these are actual direct quotes from patients that I've cared for. So the first one, I'm so weak, I can't even pick up my 5-year-old. All I can do is sit in a chair. I'm not who I used to be. So this I would assess as having spiritual distress around the first one, meaning in the face of suffering. and coming to terms with an adjusted sense of self and a challenged sense of who I used to be and who I am now. If I can't get these legal issues settled and bring justice to my daughter, then my life will have no meaning. The patient looked me straight in the face and said, my whole life will have been for nothing, which is an awful way to feel. Can you imagine? And so this person, I assessed her as having a serious distress around a need for integrity, a legacy. What was the meaning of her life if she couldn't get these issues with her estate and some other kind of legal issues related to her daughter? This patient said, my daughter needed me and I wasn't there for her. I'm all she has, and now she's going to be alone. So her distress was around profound concerns about relationships. I also heard a patient say to me, I saw my dad die at home and it was horrible. I don't want to die like that. So this person had concerns around the process of dying, of death. This patient said, I don't think I'm going to see my mom in heaven. She was amazing. I've done a lot of bad things in my life. I should have known better. So this person was afraid of what happens after you die and whether he was going to go to heaven or not. This was a family that said to a patient was in the cardiac ICU and was on an Impella, which is kind of the highest level of cardiac intervention. And we were sort of at a standstill in terms of what was next. And his family they were a lovely family, very devout. And I remember his mother and his sister kept saying to him, stop questioning your faith. Don't you trust God's word? Try the treatment, try these treatments. And so for them, there were issues related to making decisions about treatment. Then I saw a patient who said, I was raised not to ask questions like, why me? You just deal with it. Like when my mom died and my niece died, but now it's like, why me, God? What did I do? And so this person was having real religious and spiritual struggle, kind of like questioning his relationship with God, his relationship with like how we question and how we think through these things. And then one time I had a patient that needed the partner wanted him to have immersion baptism as he was actively dying. That was a little bit tricky and difficult to deal with. We ended up working with the patient's pastor, but it was sort of one of these frantic moments where his partner was like, I need him to be baptized right now. Because for her, it was like, if he wasn't baptized, she was convinced that she would never see him again in the afterlife. And it was a very important spiritual need that had only sort of come to her attention, like as he was actively dying. So she felt like it was a crisis. And so that was something that I and my colleague, who's a physician, and I were working on to navigate with their pastor. Also, we had a patient who wanted to be cryonically preserved before end of life. That was a new one for us. And so he had a lot of distress around whether his check would clear before he died, so that he could know that he was going to be cryonically preserved. And so that was fascinating because there were some ethical issues around it in terms of his care preferences. He really wanted to, go to the ICU. He was having respiratory issues, respiratory failure. And he said, well, I want to go to the ICU because I'm willing to do that for a certain period of time if I can ensure that my check will clear for my cryonic preservation, which to him was a very important sort of existential spiritual value. So that was a really interesting one. Thankfully, his check did clear. Okay, so how do we communicate all these things to the team, to our colleagues? Let's think about why. So let's go to the little circles on the side. So we communicate these to our colleagues by one-on-one follow-up. If someone says, hey, could you go see this patient? Always try to go back to them and say, hey, I was able to see them. Thank you. And this is what we said, and this is what I did, and I appreciate it. I really feel like, or if you weren't able to see them, they were out, off the floor or something, still go back and say, I wasn't able to go, but I wasn't able to see them, but I'll go tomorrow. Super important to follow up. Also, we communicate our assessments at family meetings by advocating and naming what we've learned about our patients. And we also communicate this by charting. So we chart for a record of what happened, yes, and to indicate to the team what we're doing, why we are doing it, what's coming next, and how this impacts the bigger picture. And, I do think people read our notes. I mean, I suppose I remember times you feel like you write this long note and you're like, is anyone actually reading this thing? But I do think there's a way to write it that facilitates the reading of it. If you write it in kind of a concise way, put the most important information at the top, as I'll show you, and to use concise language that gets to the point and communicates kind of what we've learned that's unique. Okay, so I'm going to here's an example of a chart note that similar to what I wrote. It's actually a little long, but I think it's an okay one. So here's what I wrote. I provided initial spiritual assessment as a member of the palliative care team to address spiritual needs, hopes, and resources. Referred by palliative care NP as R is expressing sadness and existential questions. Now here's the background, the social history, kind of the FICA piece of things. He's a married professional DJ with 3 children. He grew up Protestant, does not have a particular faith community or spiritual practice. Engaged at length in sharing about his family background, difficult childhood, and faith questions. Quote, I was raised not to question God, but I have questions now. He indicated spiritual distress related to his sense of identity, isolation, and loneliness, and uncertainty of his prognosis. Quote, I want to hope for the transplant. He was awaiting a liver transplant, and I know it would take a miracle. He spoke with the hospice liaison yesterday, and I provided further clarification about hospice care at home. My plan is to engage R in conversation about his sense of self, sources of comfort, including prayer and music, as he's a DJ, this is like what he loves, and ways to find peace in the midst of this uncertainty. I will continue to follow and collaborate with members of the care team. So that's what I wrote. Now, it's not saying this is the perfect note, but I think it's a pretty good note. I think it indicates why I was there, who referred me, and what was the reason, a little bit about the patient's background, and then really focusing on the key stuff, which is spiritual distress, his needs and his hopes, and the resources that we're working with. No. Excuse me. Okay. So here's some quick do's and don'ts for charting assessments. And we'll have some time to discuss. And I'm open to, I don't think this is necessarily the be all end all for charting. I don't think I have the final word on it, but this is just in collaboration with my colleagues and with chaplains that I work with, what I think. So do demonstrate collaboration with the interdisciplinary team. So you do want to show why you're there, who referred you, and what the reason was. You do want to convey information and concrete things you observed. Do include the referral source. And I like to include, is this an initial assessment versus a follow-up visit? Sometimes my follow-up visits are shorter. It just depends. Do quote the patient, being mindful of the legality of the document and making sure not to take sides. You can always quote the patient within reason, but keep it short and classy. So we don't want to say something like, Gina was upset that the nurses are not responding to her pain and ignoring her. That is not a good plan, even if the patient said the nurses are not responding to my pain and they're ignoring me. But instead, because that is a little tricky, but you want to say something to the effect of, you can report on what you saw. Gina was tearful and she said, I feel upset and I'm worried that I'm a burden. That's reasonable, okay? And of course, you can follow up with the nurse and say, yeah, I mean, I know she's been calling you a lot, but like, I wonder what's going on with her. And, boy, she keeps talking about her pain. And so you have to understand that like the nurses are doing the best they can. The physicians are doing the best they can too. So you can hear what the patient is saying without making it seem like the team is not doing their job, right? The best way to do that is just to talk to the team. You don't want to make promises that you might not be able to keep. Right. You don't want to say, I will return at 2 p.m. tomorrow. What if you can't? Or vague open-ended promises. I will follow up-ish. Okay, what does that mean? You could say, I will plan to contact the priest for sacrament of the sick this week or something like that. That's a little bit more open-ended, but clear enough. And also really important, you don't want to use any diagnostic language beyond your scope of practice, like depressed, anxious, any kind of clinical terms that are beyond our scope. If the patient says, I'm feeling depressed, you can quote the patient saying, patient said, I'm feeling depressed. But you don't want to say, patient is having anxiety or something like that, because those are technical terms that are not appropriate for us to be writing about. That's my opinion. I think it's I think that's kind of a consensus. Okay, this is a little bit funny, but try not to use chaplaincy jargon like a held space and I've seen all of this in actual notes. I provided a non-anxious presence. Okay, I know we learned that term in CPE, and then sometimes we think to ourselves, like, what is my role here? The patient and family are freaking out. So my role is to provide a non-anxious presence. But if you write that in the chart, I provided a non-anxious presence, it's very odd. And that is not a term that anyone would really understand, I think. And it makes it seem like you're anxious and you're trying not to be. Okay, so let's not use those things. I've also seen this, the patient has a reconciliation dynamic. So that is language from Spiritual AIM, which is a wonderful, excellent spiritual assessment, or like a self-worth dynamic. But to say the patient has a reconciliation dynamic, no, I don't know. You could talk about what the dynamic is about, okay? Reconciliation with whom, or with God, or what, okay? But you don't want to use those jargony things. And also, this is a little bit funny, but I offered prayer. Yeah, but did you do the prayer? I did a very unscientific poll of my medical colleagues, and I said, if I wrote in the chart, I offered prayer, would you think that meant I did it? And they said, no, I would feel like that means you offered to do a prayer, but the patient didn't want you to. We say offer, right? Sometimes that's like a spiritual, I offer this. But again, you could just say prayed with patient. So we want to use active verbs, addressed spiritual needs, prayed and discussed XYZ, identified sources of spiritual strength, explored questions about relationships. Here's some other handy ones, identified music, prayers, readings, address existential fears, facilitate life review, celebrate positive news, celebrate a good outcome of surgery, clarify spiritual questions, deepen theological reflection, reconnect with spiritual practice, provide guided meditation, normalize grief, affirm family relationships, those kinds of things. Again, we have a particular skill set of things that we do based on how we assess the patient's needs. And so it's really important to, I talk about this a lot, I think, but it's such a balance between, doing and being, right? I think as chaplains, we're trained, initially we want to go in our training, wherever we are in our training, and we want to do all the stuff and do things and fix things and help. So then we're taught, back up, be quiet, hold space, have a non-anxious presence, kind of be calm and have presence. That is totally great. And actually choosing to do that is actually a very powerful intervention, right? Choosing to be quietly present with someone and to stay, kind of hunker down with someone and be there with them is actually a very powerful intervention that is not that common. That said, we don't only hold hands and pray, right? We don't only quietly hold space. It's a balance, right? Between that holding of space, that presence, that excellent active listening that we do, and using our professional assessment to really identify what we can do to address the current situation. Of course, we're not trying to fix things. We're not trying to just, go in and read something and leave. As my CPE supervisor used to say, prayer is not an exit strategy, right? You don't do the visit, and then be like, okay, pray and then leave. Because I think you might find, and I'm sure you all have found this, is that when you pray with someone or meditate with them or kind of have that reflective space with them, oftentimes it actually opens up a much more beautiful dialogue, or a kind of a more brave, honest dialogue. So allow some time after the prayer or the meditation to really talk more. I think holding that kind of vulnerable, kind of heart-centered prayer or whatever with the patient can really allow them to open up and to really be present in what's going on with them and to share that with you. It's, and to develop trust with them. So yeah, again, it's a mix of presence. Presence is great, but also we have a skill set here, right? Why would the hospital pay someone just to be present with a patient and hold their hand? That's what wonderful volunteers are for. Totally great. But again, just to really, in our charting and in our work, to understand that, like, just as any other member of the clinical team has assessments and interventions and a plan with intended outcomes, so do we. So here's another example. Oops, I wrote R, but I meant S. So this is a little bit of a shorter note. Provided follow-up visit to S, who has, quote, come to terms with what is going on and is now seeking to be anointed. She initially saw the sacrament of the sick as, quote, giving up, but due to team support and family conversation, she is, quote, ready to be blessed. That was what my patient said. I explored her hopes about going home on hospice. She wrote, I want to sit, she said, I would just want to sit in my garden and give my kids a hard time. Her daughter, who was crying at the beginning of the visit, laughed and said, this sounds like the mom I know. I like this note, and this was a real visit, and I liked the experience because it indicates it gives you a good snapshot, like a vision of what was happening, what we were talking about, the process, and also kind of movement, I think, within the visit, right? So the daughter was crying, the patient saw things as giving up, she saw kind of talking about the sacraments as giving up, but now due to our team support and further conversations, she's ready to be blessed. And the daughter, who's crying and feeling awful at the beginning of the visit, kind of, laughed and felt a little bit better. And she was like, this is the mom I know who's going to give me a hard time. And so that was really, it was beautiful. And it shows that those conversations that we've been having over time have made a difference. And finally, at the end of my note, we discussed her family dynamics, and I affirmed her intentions of focusing on her many blessings and all the good adventures I had with my husband and kids. I will continue to follow until home hospice discharge. So again, no note is perfect, but I think this one is okay because, and this is not an exact note from a real patient, but it's sort of related to a visit I had, just so you know. But I think using quotes can be really helpful. And it's a quick way for the patients to really, for the care team to really hear the patient's voice, or hear the family member's voice, and to remember that we don't know the outcomes of what we're doing unless we're observing them, right? Either we see someone who looks better, we see someone who's more engaged, we see someone who expresses to us that they're feeling better, or they're feeling more hopeful, or they feel heard. We can't always fix everything, but we can make someone feel heard and seen, and we can indicate that in our notes. So this is just kind of a quick summary. Another spiritual assessment that I was trained in is what's often called like the Lucas Discipline for Pastoral Caregiving, which is really needs, hopes, and resources. I think I use kind of a hybrid of the PC7 and needs, hopes, and resources. So again, we're looking to provide a snapshot in the chart. The patient or family need to feel like, for example, to feel like they fought as hard as possible, to tell their life story, to document their experience on a blog, to express anger, to feel like I'm in charge, to know that I did all I could do for my sister, to know what's going on. So those are some things that the patient feels like they need to XYZ, and you could write that in your note. Or the patient is hoping, there's my churching of my baby and my husband. The patient or family is hoping to feel the love of family as the patient dies. Remember, needs and hopes are a little bit nuanced and different, right? So those are good questions to ask people. They're hoping to attend their granddaughter's baptism. They're hoping to grow old with their spouse. They're hoping to reconnect with God, or to have dignity in death at home, or to come to terms with their terminal diagnosis. This is important for the care team to know. It really is, because then it can really be a priority. And what resources do we have to work with? We have religious and spiritual resources, community, social, family and friends, artistic, musical, nature, beauty, dance, exercise. But remember to be broad. What brings you comfort? I can think of a patient who loved poetry. She was sort of a spiritual, non-religious person. She loved poetry. She loved T.S. Eliot. She loved Whitman, and she loved Madonna. And so those were the resources that we had to work with. And we played music, and we had sort of dance party in her room. I mean, she was bedbound, but an arms dance party. And, those were the resources that gave her peace and calm and beauty at the end of life. My patient, who was the DJ, we did basically a study of the Netflix show, The Invention of Hip Hop, and where we went through and just like talked through all the different, or the evolution of hip hop. Yeah. Where we looked at all the different like hip hop DJs and MCs and groups and kind of talked through all these different things. And I kind of challenged him and engaged him. And I did it, well, it was fun. And also I did it because this patient in front of me was a DJ. That is who he is. He loves music. And so I was able to engage him in something that he sees as his like deepest identity. And so in doing so, I'd like to think that I was able to kind of bring him back to himself, bring him back to what gives him joy and peace. And yeah, it wasn't, traditional prayers, but it's great to listen to Tribe Called Quest with a patient. That's just as beautiful as anything else, I think. So just kind of as a summary, I think we'll have about, 15 minutes to do some discussion if we'd like. Try to convey who and what is before you, a snapshot of the person and family and their values and beliefs. Really try to convey any spiritual distress. And if there aren't a lot of spiritual needs, or if there isn't a lot of spiritual distress, you can just simply say, Sue indicated that she doesn't have any particular spiritual needs at this time, or she did not indicate any spiritual distress. I will continue to assess this, or something like that. So if you don't see any distress, that's okay. You can say that too. You can say the patient finds comfort in their daily meditation practice and, whatever. So the point is you want to navigate that, not just what you did in that visit, but also how what you did connects to the bigger picture. So again, needs, hopes, and resources, and really themes running through his or her story. Try to look back at your notes if you get to visit patients more than once. In hospice, I used to visit patients, every week for a year. So I really got some kind of longer term changes and relationship that grew. Sometimes I see a patient once, sometimes I see them 25 times. But again, to look at the themes and to revisit them in your notes if possible. And also, again, you don't want to surprise anyone on the team with your note, right? Anything that's really unusual in the note that you're going to write, you should also say it to either the floor team, your palliative care colleagues, whoever, someone that needs to know, right? You don't want to surprise anyone and they read your note and you're like, whoa, I had no idea about that. So again, we want consistency if possible. I know it's sometimes hard to track down the people that you need to talk to. I know that I'm always like running around trying to find the team, but that's part of it, right? We have to communicate this to the team. We don't want to go in, do the thing, and then leave, and then see you later. Instead, we really want to share, again, our skills, our assessments verbally as much as we can, and also in the medical record. Okay, I'm going to add this. I know that it depends on your institution. This is kind of like a creepy picture, but I wanted to find one that sort of indicated this concept about open notes. So at Mass General, we do have open notes. And I know that I think MemorialCare, where Katie is, and some other places, will eventually have it, don't have it right now. But it's really important to picture the patient and family reading the note alongside you. Picture them lurking behind your shoulder, reading it, and for every single note. And the thing is, this is not a change in terms of access, right? Patients and families have always been able to read their notes. It just was like a longer process and took a lot of work to access them. But now, the second that you write it, basically the patient can see, the patient or family, if they have access, can read your note. And so you want to be really mindful of your language. You want to be mindful of the quotes you use, make sure they're accurate. Not to make it seem, or cast kind of a value judgment on what's happening, right? I think just picture the patient reading it with you and think, does this sound appropriate or not? And I think that will help you. I mean, to me, that was the biggest help in navigating this open note situation, is just to remember that, they're reading this. And the thing is, what's really interesting too, is I've had some patients where I write a note And then the next time I do a visit, they're like, oh, I read your note, and I think that was really interesting. Or, boy, I hadn't quite thought about it in that way. Or, it became like a dialogue. It was super interesting. And so they commented on my note. I do the visit with them and we talk about the note. We talk about what happened in the previous visit. Then I write the note for that visit, knowing that they might read it. So it's actually an interesting way to kind of help the patient and family, I think, feel seen and heard. And I don't think it's a negative thing. I really don't. I think it's good for us to have accountability and to have that openness. So we're more like a partner with the patient and family, instead of just someone just kind of like writing your opinion of what happened and they never see it, but really to advocate and to help them really feel seen and heard. So let's see. Okay, it's 46. So I am basically ready to have some Q&A. Katie, if you want to pipe back in, feel free. This is the evaluation. So if you do your smartphone at this thing, it will magically give you a survey. We've really evolved, haven't we? So
I know, right?
Yes.
And this is depending on what you need for your institution or for your discipline. For our nursing and medicine colleagues that are among us, you do get 1 hour of CME for attending this, and that's how you will claim that. I will drop a link to that in the chat too.
Okay, so go ahead and stop sharing.
You can close that. Yeah. Okay. So a couple of great questions came up in the Q&A, Sarah. A couple of them about open notes, which is what you were just talking about.
Yep.
Can you talk a little bit more about how it's changed your practice of charting? If there was something that you would include before and you don't now?
Yeah. Well, I think luckily, I was always trained from the beginning to really remember that the patient can read your notes. So that was good. And I remember hearing horror stories about it, truthfully. I think I just luckily had a CPE supervisor who really kind of was very clear about that. Remember, because, some student had written about oh, the patient's messy divorce or just things where you're like, oh, we don't need to write about that. Or you could write in a more, if there's difficult stuff, right? Sometimes we hear some really difficult stuff, trauma, relationships, abuse, all these really tough things. You can allude to it in a way that's honest without getting into the details. I think I always did that, but I think it just heightened the importance of doing that. So you can allude to difficult family dynamics or a challenging childhood or something like that. I think that's what I do. I do try to quote the patient, but I try to be very accurate with the quote. I don't want to make them feel I choose my words very carefully, right? I don't want the patient to feel like I'm judging them or that I'm saying something that's super vulnerable, right? I try to be honest and compassionate, but also clear if there's something that's really causing them distress or causing them worry, to indicate that, but not to just drop it. Instead to indicate that and then indicate how I'm addressing it. I'm not sure, I don't really know if it's changed my practice too much, other than I'm just incredibly aware that the patient is lurking behind me at all times, which is a good thing. I think it's good for us.
Yeah. I've even heard another chaplain, actually, I think, say that they sometimes will use open notes as part of the visit. And so they'll say, I'm part of your care team. And so as part of this, I'm going to write. And so what can I say that would be helpful for me to communicate to the rest of the care team? How would you like me to summarize what we've talked about today? That's a really high degree of transparency, but strikes me as something that could be helpful.
Yes, I totally forgot to say that. And that is totally a great point. And actually, we did a webinar, I wish I had the link handy, with Transforming Chaplaincy about open notes. It was yeah.
I don't have it handy either, but I think there are a couple Transforming Chaplaincy folks on here. So if somebody has that link handy, that would be fantastic.
It's called best practices or towards best practices for opening up chaplaincy notes. But so there are some good examples in that one too. But yeah, great point. Right. Depending on, I think a lot of my patients are just really, really sick. And so sometimes like the level of dialogue is like, we're not having these like super long conversations, but if you can be tell a patient like, hey, like you said, I'm going to write some notes. Is there anything you want me to put in or leave out? And also what's nice about it is it reminds them that we're a part of the medical team and that we document.
Yeah.
Maybe they don't know that, right? Like what if it's possible that they think maybe we don't document. I mean, back in the day, I didn't document. I wrote it on a tiny sticker and I stuck it in the paper chart. I mean,
Yeah.
at the risk of dating myself. So, that's really important.
Yep.
Oh, there are a lot of comments. Let's see.
There
Oh, Shelley Varner Perez to the rescue.
I know.
Thank you. Fellow, one of our rock stars. Thank you, Shelley.
Another question came about specifically, I think, in your chart note. How do you use the PC7? Because there's always a danger, I think, if you have a table and numbers. We see this even with a functional assessment for our palliative care providers. You just stick a table with numbers, that's an assessment in there. Folks outside of our discipline don't know how to interpret that. So how do you, do you put the table in? Do you just use it as categories?
Yeah. So I do not put the table in, but I try to use the language of the PC7. So like, for example, with that first one, I wrote like the patient is experiencing spiritual distress around concerns about like family relationships or something like that. So that's one of the categories. I try to use the language. I have like a handy thing that I actually have a dot phrase. I don't know if y'all use dot phrases, but I have dot phrases related to those. And so just as like a handy reminder, a dot phrase for anyone who doesn't use them is like where you type it in and it like pops up, a handy thing. Like in the note, like a little sentence. So I just say, I don't use the score or anything right now because I feel like it's just not super helpful, but basically I just use the categories. I say patient is experiencing some distress or questions. Sometimes I don't say distress. I might say they're asking questions or reflecting on the concepts of their family relationships. And then I add a quote. And then like, that would be kind of the primary example. I don't know. What do you do? So you don't use the table. Do you use the PC7 in your daily practice?
No, I think that most of our chaplains don't use PC7 or at least not the table. But that's interesting because it's sort of like you have that framework in your mind and then you translate that into something that's meaningful in the chart note.
Yeah. I mean, isn't that so much of what we do, right? Is hearing like either like super complex theological concepts or existential questions and translating it, to maintain that integrity, but also to communicate it to the medical team in a way that they can hear it quickly and efficiently and how it impacts the care, right? I mean, I think that's always the key. You can say all the things you want about spiritual and existential distress, but what we need to piece together is that through line of how those questions are impacting or affecting the patient, whether it's their decisions, whether it's their willingness to get out of bed in the morning, right? They feel like there's no point because they feel like, they're having existential distress about XYZ thing. So they don't want to get up. That's why they don't want to do PT, or that's why they don't want to do, and so all these things connect. And so to find a way, it's a learning process for me to be concise about that is important. Tips paper. Thank you, Shelley. Also.
Yes. Yeah. So can you give an example maybe of a time when somebody brought up a sensitive topic, maybe talked at length about a messy divorce or talked at length about, because this can happen, particularly patients at end of life or struggling with serious illness, and they think there was something that happened years ago, a decision I made, a situation I was in, and now God is punishing me for that now. And that can be a really involved conversation. How do you handle that with sensitivity and confidentiality and make it concise?
So I think I err on the side of not including a lot. I really don't include things. I really am as minimal as possible in the written note. I may elaborate one-on-one in conversation with colleagues, certainly. Like I will talk with a colleague and tell them more openly about what I've learned. I can think of a time like I had a patient years ago who, this was a long time ago. I could probably think of a more recent one, but this one always stands out to me. But there was all the stuff going on with the Catholic Church. She was a Catholic patient, stuff going on with the Catholic Church and all the crisis and abuse and all these problems that was going on. This is really the kind of, I was also working in a Catholic hospital, so it was kind of heightened. And she said, she also had a psych history, which I think changed her perspective a little bit, but she said she'd had an abortion and she felt like God was punishing her and punishing, anyone in the church and this and that. So she was connecting those kinds of things. Now, I would not put that in the chart. But what I would say is I engaged in an in-depth discussion, maybe, or something like with the patient about her religious upbringing. And she worries that some of her life choices, are causing God to punish her or are the source of her distress. And then I would share it with a team member if I felt like it was appropriate and relevant. But it's like such a balance, right, between what we hear and learn and what we need to share with the team. I can think of a lot of like family dynamic stuff that you just would not want to document. Also, the thing is, the thing that's also tricky is sometimes we're not sure if what we hear is like exactly actually happened, or how we're experiencing those kinds of things, right? Not that our patients aren't telling the truth. They're telling their truth, absolutely, and it is real. But at the same time, if they say that they were, mistreated or abused at their previous hospital, like you can hold that, you can respect that, you can talk about it with the team because it's relevant to their experience now. But at the same time, you don't want to document that because that's very tricky. So again, the patient had a difficult experience. I mean, that you kind of have to smooth over it sort of in some ways.
Yeah.
But you can indicate that things are difficult or things are hard or the patient is having questions or worrying. Those kinds of things are real and that's okay to say them. And a fellow clinician can follow up and ask them about that and maybe they'll share that too. But again, I err on the side of saying less, just in the interest, but still sometimes quoting the patient if I think it's appropriate.
Mm-hmm. And maybe just a word or two about, somebody asked a question about how do you navigate advocacy and documentation when, so sometimes the patient will say, I feel like the nurses, I think this is maybe to your question about like, I feel like the nurses are ignoring me, not bringing me pain medication. And sometimes that's their perception. And sometimes really we are understaffed and they can't respond as quickly, or so there are larger systemic issues that are going on and genuinely present. And so how do you juggle that in your documentation?
Yeah, it's tricky. So I will say on the one-on-one side, I always do talk to the nurse or whoever and acknowledge like from the outset, like, I know that you guys are, this has been a rough day. And like, she's really ringing that call bell a lot, like just to normalize maybe their emotional experience of what's going on. And like, boy, is there anything we can do just to, I try to like interact with the nurse or the medical provider on a human level, first of all, to follow up because of, it might be true that their pain is not adequately controlled. So I will say, I asked, when asked, patient so-and-so indicated that they indicated discomfort and I followed up with the nurse, which I did, I followed up with the nurse and followed up with, the PalCare attending to discuss, the pain management or something like that. But I mean, I try to, again, acknowledge that I talked about it with the patient in a way that is not accusatory or implies that they're not doing their job, because again, they're not, I mean, we all know that we're all understaffed and we're overworked and we're all burned out a little bit. So I do, but like, I think I do a lot more advocacy I can through one-on-one collaboration with my colleagues. That's where, to me, like the real stuff happens, because again, we don't want to surprise our colleagues with some very special, interesting knowledge where that they read it and they're like, wait, why didn't she talk to me about this? Right. So we try to like distill the stuff into the note in a way that like aligns with what you've already talked about as a team.
That's super helpful. Well, we have questions. People are really had lots of questions that we couldn't even get to. I'm so appreciative of everybody who attended today. And Sarah, just your warmth and your wisdom are always such welcome gifts. So thank you for your time today. I will one more time drop my email in the chat. If people would like a copy of this recording, please do email me. And other than that, thanks again, Sarah.
And thank you all for your lovely comments. This is very kind. I really feel like clearly there's like a lot of wonderful people on this webinar today. So I just want to say thank you. And, everyone keep up the good work.